Okay, hello again. Dr. Mintz here. I wanted to go through a case of small bowel obstruction. We are accustomed to seeing this in the past on plain radiographs, and CT has been very, very helpful in detecting and evaluating small bowel obstruction. And so we're using it very, very regularly. We see a lot of patients with possible small bowel obstruction getting CT. And the truth is, in the past, it used to be a real difficulty for the clinician to decide if someone had a serious abdominal situation, such as small bowel obstruction that often requires surgery, or if it was just a stomachache of whatever sort. This is an example of small bowel obstruction. So this is a coronal series, and if you look at it, you say, okay, looks like there's some dilated bowel. How do you know it's a small bowel obstruction and not just an adynamic ileus? One of the most important findings in identifying small bowel obstruction is not just dilated small bowel, but reduced caliber distal small bowel and reduced caliber colon. The reason is that the bowel reacts to an obstruction by trying to clear it, and it tries to clear it by increasing overall peristalsis, and that occurs not only proximal to the obstruction but also distal. The bowel doesn't know where the obstruction is, so it just increases peristaltic activity, and therefore anything distal to the level of obstruction tends to get pushed out. So the small bowel distal to an obstruction and the colon tend to be of reduced caliber. Sometimes the colon will retain a moderate amount of fluid or air in the right colon, but usually will reduce the amount of air and stool in the transverse colon and left colon. So looking here, we can see that there is a reduced caliber colon. I mean, look at the diameter. And a lot of radiologists don't really rely too much on measurements, but here I find it useful, and I usually even include it in my report. So here is a colon measurement, a diameter of 1.7 centimeters, and here we have a small bowel diameter of 3.9 or 4 centimeters. I usually find that small bowel 3 centimeters or more is obstructed. That doesn't mean that it can't be less than that, but if it's less than that, it is less clear that it might be that it is a small bowel obstruction and not an ileus. So this is clearly well over 3 centimeters. Okay, so that's one of the findings, all right? Dilated small bowel, especially greater than 3 centimeters, and a reduced caliber of colon. You can usually look in the right lower quadrant for distal small bowel, for terminal ileum, basically. That's the one place where you know it's going to be, if it's small bowel obstruction, terminal ileum will be distal to any small bowel obstruction, basically, no matter where it is. Okay, so if you look down here, it may be a little hard to identify what's what. This is presumably right colon, and it is quite small in caliber. But these little loops down here are small bowel loops, such as this. See that? That is, and here, not sure, maybe that was a vessel. It can be hard to tell. But you see a number of structures. Yeah, that's small bowel. So it's coming out of the pelvis here, and it kind of courses up. So this is small bowel right there. This is small bowel here. So it's really quite narrow, and then it comes into the right colon as a terminal ileum. So clearly a reduced caliber of distal small bowel and of colon. Very important. Very important. Very common thing to look for. These findings are really as clear as any you will ever see in this regard. So it's a common problem, and we look at it often, and it is very useful to have someone whose eyes are open to this possibility, who will look and say, I think there's a small bowel obstruction here, because it's nice to grab that, for a radiologist to grab that case next instead of just a chest x-ray, because the patient's in a great deal of pain, and an upper GI, or rather an NG tube can be placed to decompress some of the bowel, the stomach, and some of the proximal small bowel, and make the patient more comfortable, and get that information to a surgeon in a timely manner. Maybe 10 or 15 minutes can make a difference between whether the surgeon has left for home or not. Okay, other things to look for in a small bowel obstruction is ascites. Do you see ascites here? Do you see it? Yes. You can see it here, left lower quadrant. See that? It's fluid attenuation. Let's see, we should be able to get a mean of 17 Hounsfield units, 18 Hounsfield units. Okay, so that 18 Hounsfield units is a little high for some types of ascites, or free fluid, but the situation is such that regular ascites, like you get from cirrhosis, tends to be between -10 and +10 Hounsfield units, but occasionally an exudative type of ascites, what they call exudative, meaning where it's kind of being pushed out from an organ, such as pancreatitis can give you an ascites that's a little higher, in the teens, for example. So this is not uncommon for it to be a little higher like that. Okay, so ascites. And what else can we look for? Well, you want to look for the location. Most of the cases you will see the patient has had prior surgery, and that is the cause of the obstruction. The surgery, as minor as it may have been, produces what they call adhesions, little fibrous bands. So if you open up a virgin abdomen and you have all the bowel loops in there, they've never been exposed to air, they've never been touched by something foreign, and so that manipulation, air exposure, I'm not sure what exactly it is or how far we have gone in understanding why people get this, because they still get it. We haven't been able to prevent it. But people get adhesions, and they subsequently cause little bands that obstruct bowel. All right, so where is the obstruction? It's often helpful, although not necessary, but it's helpful if we are able to tell the surgeon where in the abdomen the obstruction is. Often we'll know because there'll be a bunch of surgical clips here, for example, right lower quadrant, and you'll see a transition point. You'll see where small bowel abruptly changes caliber and becomes narrow. I don't see that here, not right at this point, but you can already tell that that all the small bowel here is dilated, and the only reduced caliber small bowel we're seeing is way down the right lower quadrant. So it's a pretty distal small bowel obstruction. This is jejunum. It has those folds and marks of jejunum. Some of these look like ileum, more distal small bowel without the clear markings of jejunum. But one of the nice findings is what they call a small bowel stool sign. Of course, normally you wouldn't have stool in the small bowel, but a stool-like appearance, flecks of solid material mixed with air, are the typical appearance of stool. So why would you get that in small bowel? Well, if you have small bowel like this that is normally pushing content through, and it's usually fluid because that's how the small bowel works. Everything is dissolving in fluid, and you have exposure of these fluid contents to all of the surfaces of the small bowel for absorption of nutrients. So it needs to be a fluid type of content. It's when it gets into the colon, beginning the right colon, that fluid is extracted in order to create formed stool, which is not our goal necessarily, but but retention and preservation of fluid, which itself is a vital nutrient, as it were, is an important reason for having this water absorption. If you have an obstruction, let's say in this area right here, one thing you'll see first is that contrast has not yet gotten there. So that tells you, let's see, is this distal? Is this near the obstruction? Is this near the obstruction? Or is this? Well, you can clearly see that this is, because it doesn't have any of the oral contrast yet. So you can see oral contrast has progressed through bowel but has not yet gotten here. Here is also what they call the small bowel stool sign, and it is not one of the best examples of it, but it is sufficient. And what it is showing you is that there are these little speckles of air, which generally you don't see in small bowel ever, or nearly ever, okay? And the reason is that if this is the bowel, the small bowel here, and you have a narrowing in the bowel like this, at that point, the bowel is trying to push it through. Fluid can get through, but solid material can't. So a little bit of the solid material that is in small bowel can start accumulating there and creating this appearance of small bowel stool or small bowel stool sign. So very helpful finding in identifying the area of obstruction, and that's very helpful to the surgeons if we can say this is where it seems to be. And I can see that this loop is coming around here and then over this way, and then I think that's where it's narrowing down. You see how we lost it? I'll go back, and you see the bowel coming over this way, and then it starts to narrow, dun, 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 and then it becomes these little very narrowed loops of small bowel that are the terminal ileum. So some very characteristic findings of small bowel obstruction. Yes, you probably have noticed that some of the walls of the bowel here are thickened, and in this case I'm not sure why. It may be some inflammatory process. It could be just the severe peristalsis in that area, but it does look abnormal. But I don't want to spend too much time on that. I think you get the general principles of what are the important salient features of small bowel obstruction. Now let us look at the remarkably beautiful anatomy which we have here. And it don't get no better than this. Here you have the superior mesenteric vein, and you can see how it has its tributaries, the venous drainage from bowel, coming from bowel, and converging on this superior mesenteric vein, which then continues superiorly to the portal confluence, and then continues as the portal vein into the liver. Let's follow that portal vein, and we should see it branch off to left and right, sure enough. Okay, now backing up, portal vein, superior mesenteric vein. Okay, this looks like inferior mesenteric vein because it looks like it is coming from bowel over here and converging on superior mesenteric vein. So that looks like where the coalescence of SMA and or SMV and IMV is occurring. And then here we have, what structure is this? This would be a nice one for me to use in an exam and say, well, okay, what's this? What's this? And what's that? Basic, important. I think you're hopefully comfortable with those things now. What do you see about this vessel that distinguishes it from this? It's surrounded by fat. You see the dark gray adjacent to it? That's fat. And so this is superior mesenteric artery, and it goes down in from the root of the mesentery here, our little home spot around the pancreas, and branches out to provide arterial supply to the small bowel. What does the SMA originate from? Where does it emanate from? It emanates from the abdominal aorta, proximally, and it branches off just after another artery. What is that artery? Iliac artery. Those are questions I could easily, I think, ask on a test such as that coming up. All right, let's look again at this. Okay, I'm wondering, where's the splenic vein? Here's portal vein, SMV. Splenic vein should be coming in here, right? What is going on? Where is the splenic vein? All right, there's a spleen. There's the spleen. I mean, I'm right with you guys here. I'm trying to find it. That's pretty small. That's pretty small. That's splenic artery. Unusual. We can see that this is pancreas. That's splenic artery. So it's hard to see. Here, it's coming over like this. And we just kind of lose it. So here you can see it's just kind of anterior, a little more anterior right there. That's where the convergence of splenic vein is arising and continues off that way. So this is splenic vein and this is splenic artery. And they got so close to one another, it was a little difficult to distinguish one from the other. Okay, so nice view of the abdominal aorta. And, well now, look at this. Here is the abdominal aorta, and let's come out anteriorly, one cut, and we have 1, 2, 3, 4. What are those vessels going to be? Well, this you would look at ordinarily and say, how can I tell? Well, the reason is, this is the first branch off the abdominal aorta after it has passed through the aortic hiatus, and you would say that that is iliac artery, which gives off what vessels? That's a good question. Certainly could ask that. Hepatic artery, splenic artery, and left gastric. Left gastric is the one that kind of hooks up and then curves along the lesser curvature of the stomach. This would be then the superior mesenteric artery. Let's see if that's true. We'll go out a little farther. Surely enough, it is surrounded by fat. And then what are these two? Well, what two arteries would come off the aorta up at this level? The renal arteries. So here again, you don't look at it and say, what does that look like? Does that look like a renal artery? Gee, what is it? I'm not sure. It all is about anatomic relationships. If it's coming off distal to these two arteries, there's a good chance it's going to be the renal arteries. And there are two of them. They come off at about the same level. Sometimes there's more than one on one or both sides, but the standard, most common arrangement is to have one renal artery on each side. And what vessels would these be? At the aortic bifurcation, the common iliac artery. And what is the continuation of the common iliac artery if you go off toward the femoral artery? Let's see if we can see that. Yes, that would be this length, and that would be the external iliac artery. And the branch that the common iliac artery gives off, and it may be hard to see here, when it branches, it sends off one external iliac artery that continues as the femoral artery, and it sends off a deep branch, which is the internal iliac artery. Let's see if we can see that. See, the nice thing is that basically everybody's got these things, and it's just a matter of looking for them and finding them, and sometimes it's harder than others. I can't really see it real well in this case. Let's look on the other side. Okay, there's two vessels. I'm just guessing, but they're probably the left common iliac artery and left common iliac vein, because they're running right alongside of one another. Okay, now this seems to give us, a better example of an internal iliac artery diving down here from the renal artery and going down. It's hard to see. I know I do this a lot. I know it's difficult, but you can see that the vessel is there. It may be easier to see on a coronal, and that's one of the advantages of CT these days, is that we don't have to depend on just one cut or one plane. Isn't that lovely? Okay, very nice depiction. And this is the way, of course, that you will most commonly see it. But I think it's good to be comfortable with coronal planes also. Sagittal planes have their use, but they're usually used to say, hey, I can't quite figure out what's going on here. And you've looked at it in the axial and coronal planes. Sagittal is kind of just a third view, but it's not something we use routinely, or that most of us use routinely for examination of the abdomen and the abdominal content. It is very good, though, when you're looking at a trauma patient to finish the exam and look at the spine in the sagittal plane. All right, so here we go, looking at the abdominal aorta bifurcation. Follow it here, left and right, big chunks of calcium. Watch your diets, folks. And here, okay, there we go. So here's the left common iliac artery, and then right at that point it branches, left external, left internal, and internal is usually quite a bit smaller. Left external iliac artery, left internal iliac artery. Now this is another example. If you look here and say, oh my goodness, how can I ever look at this and know what is the external and what is the internal iliac artery, or even that it's not the common iliac artery or the vein? It's all about anatomic relationships, and you would have to see the bifurcation and follow the common iliac artery out to the branch point and see that, oh yes, one is going anteriorly and one is diving deep, and that's the external iliac artery, and that's the internal iliac artery. It's all about anatomic relationships. Ascites, small bowel obstruction. Oh, what do we have here? Well, this structure here is the gallbladder. We don't usually make too many diagnoses there. Once in a while we'll pick up some stones. Ultrasound is far better in evaluation of the gallbladder. But here we have the common bile duct coming from the liver. So the liver has a biliary system. The biliary tree converges and drains toward the pancreas, and it's at that same point that the portal vein is coming in and branching out to the liver. So these lower attenuation areas are the biliary system converging here, continuing as the common bile duct, which goes into the head of the pancreas, is generally joined by the pancreatic duct, which is very hard to see here. Sometimes they empty separately, and the common bile duct then empties into the duodenum. And you can follow it, and it's coursing off to the right there, and there we lose it. So this is the second portion of the duodenum. This is the pancreatic head, and it's right about at that level that the common bile duct is emptying into the duodenum. If you have biliary dilatation, you can see that on CT, because if you look here, you follow the portal venous branches, and, well, they have a little thin biliary branch along them right toward in the central area, but off more distally, you don't see thin tubular low attenuation structures, which would be dilated bile ducts. If there is a bile duct dilatation, if there is biliary dilatation, then you will see these things going out farther, and it can be quite striking. And you'll see an example of that sometime. And if you do see that, there are a number of causes. The most common is going to be a gallstone, which has passed into the common bile duct and is obstructing here in the pancreas. And a heroic diagnosis, a great finding, is to look in the common bile duct and say, oh my goodness, not only is there intrahepatic biliary dilatation, but I can see that there is a stone in the common bile duct. And sometimes it's not calcified, so all you see is that there is a round structure that is as if a filling defect in the common bile duct. The other important cause is a pancreatic tumor. So a pancreatic cancer can certainly obstruct the common bile duct here as well. Okay, so what structure is this? What's that? Superior mesenteric vein. And what structure is this? Superior mesenteric artery. Good. And how about this? And it's renal something. Is it renal artery or vein? Well, it looks like it's not going to the aorta, it's going anterior to the aorta. So that is renal vein. There is beautiful anatomy in every patient. Okay, that's it for now.